Greetings. I'm Dr. Nikhil Tandon. I'm from the Department of Endocrinology and Metabolism at the All India Institute of Medical Sciences in New Delhi. Let me give you a brief synopsis of the work we are presenting today at the RSSDI 2022. This relates to the use of a clinical decision software and task sharing to help improvement of quality of care for people with non-communicable diseases. So let me first define these two entities. So clinical decision support software essentially are engines which derive information from electronic health records and using evidence-based guidelines come up with management prompts. They could be rule-based algorithms which are dependent on multiple scenarios, and in some instances they are now evolving but yet not established using artificial intelligence. The concept of task sharing is that activities which were previously only done by physician healthcare providers are now being delegated to non-physician healthcare providers, and therefore it offloads some of the work done by physicians by colleagues who are non-physicians and allows the time spent by the physician to concentrate on medical issues, whereas additional issues can be taken care of usually by nurse practitioners or dietitians or other such trained personnel. So this talk is going to be covering about a 10-year journey which we started primarily to address the following questions. Number one, that we know that in people with diabetes you need to control glucose, blood pressure and cholesterol. We have medicines for all three, but we actually do a not so good job in meeting targets for control. So what we developed was a composite intervention, which was a technology, which is an electronic health record, which is now commonly available in many sites, a clinical decision support software, and a non-physician healthcare provider whom we called a care coordinator. And the first study we did as a randomized controlled trial was in tertiary care settings in which people were randomized to either intervention, which is the composite I talked about, or the usual care, and the care coordinator becomes the fulcrum of care delivery in such an individual. So the patient goes first to the care coordinator who takes the relevant information, does any other measurements like blood pressure, weight, enters that into the electronic health record, which causes the clinical decision support software to give a prompt, and then that advisory and the patient go and meet the doctor. So in this particular study, we demonstrated a 2.4-fold improvement in the ability to meet glycemic, blood pressure, and cholesterol targets in people who at entry into the study had poor control. And this was seen independently for glucose and also independently for blood pressure and lipids, though not to the same extent. We then replicated this study in primary and secondary care. And since then what we've done is this has now been adopted by a couple of state governments in India, namely Mizoram and Tripura, to deliver secondary care in those institutions, and an ongoing demonstration project in the state of Punjab in which we have now done this concurrently across all levels of care, but also feeding in a process of establishing referral thresholds and referral linkages so that patients can be sent up from primary to secondary to tertiary levels of care if they require that assistance, and also down referrals so that they can be brought down to the lowest level of care where stable disease management can be done. So this is a 10-year journey, and we're hoping that in time to come, and the not too distant future, number one, that this will become an option which is offered through the National Program for the Prevention and Control of Diabetes, CVD and Stroke, which is going to be now renamed as a National NCD program. We're also in conversation with the National Informatics Center to see if this CDSS engine can be added to the e-hospital electronic health record, which is made by the NIC, and we're also in conversation with the National Health Authority to see whether the framework they provide can also, we can integrate our CDSS into the framework the NHA provides, again to help deliver care overall. So this is basically trying to say that moving on from not merely the use of technology in the form of CGMSs and pumps, we're using technology in form of digital solutions using software which can then assist clinicians based on evidence-based guidelines to deliver care for their patients. Thank you.